Now I will go ahead and introduce our speaker, Dr. Brenton Bauer. He is a cardiologist at Core Healthcare Associates in Torrance with specialty training in cardio-oncology and advanced cardiac imaging. Dr. Bauer was born and raised in Southern California. After growing up in Covina, he made it the 30-minute trek to UC Riverside, graduating with a Bachelor's of Science degree in biochemistry. From there, he went an hour and a half west to complete medical training at the David Geffen School of Medicine at UCLA, where he chose to stay and complete his internal medicine residency training. This was followed by a chief resident year, helping to guide and lead their residency program. Next, Dr. Bauer pursued his cardiology fellowship at UCLA, where he was asked to serve as a chief cardiology fellow and ultimately obtained advanced training in cardio-oncology and cardiac imaging, along with preventative and general cardiology. He's been involved in scholarly work throughout his training and further practice, with multiple presentations given at national and local conferences, as well as numerous publications and esteemed journals. Furthermore, he has a passion for helping cardiology and cardio-oncology grow. And currently, Dr. Bauer serves on the Early Career Physician Leadership Council of the National American College of Cardiology, as well as he also chairs the advocacy work group for this section. He's founded and currently chairs the Cardio-Oncology Leadership Committee for the California State Chapter of the American College of Cardiology. And while all of the above is great, Dr. Bauer's greatest pride is the day-to-day work of practicing cardiology and cardio-oncology with an amazing group in the South Bay. When he's not working with patients, he spends every moment he can with his loving wife and his now 7-month-old baby boy. And there he is. So as you can see, we are in excellent hands tonight with a very knowledgeable doctor on this topic. So take it away, Dr. Bauer, and thank you for being here.
Thank you, guys. Thank you so much to the South Bay Cancer Consortium or Cancer Survivorship, for Torrance Memorial Cancer Care, everybody that's involved in putting this on. I really appreciate you guys having me here and the opportunity to most importantly speak to patients, cancer survivors. It's a really important group of people, and I'm really, really happy that this consortium is in existence and available for patients and cancer survivors as well as their family. So let me just make sure I can share my screen here. And I will play this. Make sure this works. Sorry about that. Are you able to see the slides?
Yes, you're in the present mode now. It looks excellent.
Perfect, perfect. Sorry, a little bit of technical difficulty, but I think we got it there. Thank you so much. So as I was, very graciously introduced, that was an incredible introduction. Thank you so much. But basically, the title of this is, at the heart of cancer care, and really, what is cardio-oncology, and how, what is the history of it? What are we doing with it? And what is its role really in cancer survivorship and beyond? Nothing to disclose for this particular presentation. So we'll go over, as I mentioned, as far as specific objectives, we'll go and touch into briefly the background of cardio-oncology. It is a relatively novel or newer field within the overall scope of cardiology. We'll talk about where we are in the field as well as where we're going, how we can help patients, and then transition into the importance of cancer survivorship, followed by questions. And again, just a reminder to please, as you're thinking of questions, go ahead and put them in the chat box, and we'll go ahead and answer them at the end of the presentation. So cardio-oncology really stems from the explosion of the increase in the number of patients with active cancer requiring oncologic treatment. As we can see, on this is a graph demonstrating really over on the x-axis the time from 1970s until projected out into 2040 and beyond. On the y-axis is population and millions of people, of patients. And really you can see the growth of cancer prevalence by age, and prevalence is the number of people that are suffering from cancer over this time period. And there really is a huge growth in the number of cancers that are diagnosed for likely a multitude of reasons as far as the increased prevalence itself. And there's also, and we'll go into this in cancer survivorship, the cancer survivorship, I don't have a slide for this or a graph for it, but there's a huge growth in the amount of cancer survivorship, which is truly a testament to cancer patients and their families themselves, in addition to obviously the work of oncology researchers and the oncologists and oncology community as a whole. And this is definitely a group that we are wanting to make sure we are following over time to make sure we're living as best as we can to prevent any issues from a cardio-oncology perspective. So going into the origins of cardio-oncology, really the discipline dates back as well as to the early to late 60s. Anthracyclines are a class of antibiotic that turned into chemo drugs, chemotherapy agents that are used even to this day very commonly in many lymphomas and sarcomas, as well as additional breast cancer is transitioning a little bit away from them, but breast cancer, there's a lot of use of these anthracyclines. These drugs are called doxorubicin, daunorubicin, a lot of these rubicin ending drugs that you may have been familiar with over cancer treatment in the past. And these really were noted to have significant possibilities for cardiotoxicity starting in the late 60s. And a lot of work has been done to study this, and has really been the prototype for cardiac toxicity within cardio-oncology moving forward. Dr. Dennis Slayman is an oncologist and researcher up at UCLA Medical Center, and he worked on and developed trastuzumab and later marketed as what's commonly known as Herceptin back in the 1990s. And cardiotoxicity was noted in clinical trials that got that drug approved. And we know in the use of Herceptin, mostly in HER2 positive breast cancers, about how often we have to check the heart, usually every 3 months, with echocardiograms to evaluate for any types of heart toxicity or heart dysfunction with that. And so really the anthracyclines, as I mentioned, as well as the advent of trastuzumab as Herceptin, really was the beginnings of cardio-oncology. And then over the last 20 years, really, there has been just an explosion in the science and development, really, of novel therapeutics in cancer care. There's VEGF inhibitors and other tyrosine kinase inhibitors, starting with things like sorafenib, sunitinib, which is Nexavar, et cetera, and just really, just dozens and dozens of others that have come since that time. Immunotherapy, which has been a really exciting advance in the field of oncology with respect to, we call PD-1 inhibitors, like Keytruda, for example, being one of them, very commonly used for a number of different types of malignancies. CAR-T is a type of therapy that is really interesting, that is being studied for additional types of lymphomas and other cancers, and really many, many more. And as the oncology community is using these agents more and more, we're learning at a very rapid pace about the cardiac effects, some with none or minimal, and some with more significant effects that we need to be ready for as cardio-oncologists to help our patients get through this, both during the cancer therapy to prevent problems during cancer therapy and allow them to stay on these life-saving and life-prolonging drugs, as well as to make sure that we don't cure the cancer ultimately to have a major problem with their heart within the next several years. So we'll go into where we are with the, with cardio-oncology currently. Excuse me. So really in the center, I've highlighted with this kind of red square here, the intersection between cancer treatment and the host interaction, cardiovascular risk and disease, and cancer treatment and its related toxicities. We'll go into the surrounding kind of boxes around this several slides later. This is just an introduction to the next few slides. So really, when we're talking about cancer and host interaction, we're talking about, for example, certain malignancies or other conditions that can result in cardiovascular disease. So very commonly, I'll be seeing patients that have multiple myeloma, and this can be either a condition that does not develop something called amyloidosis or does. Amyloidosis is something very much associated with myeloma due to proteins that are misfolded and then deposit in the different tissues of the body, including the heart, unfortunately. And this is something that we see in cardio-oncology and try to help with the oncologist to manage this effectively. Acute leukemias and the very, very high white blood cell counts and associated, we call leukostasis, where they're just really tightly packed white blood cells in the small arteries of the heart and other places in the body. Lymphomas and other solid tumors that may be actually impinging upon the heart itself and or causing disturbances to the way the heart functions. We have primary cardiac or heart tumors that we are luckily very uncommon, but we do see them as well. Certain pre-existing cardiovascular diseases or risk factors that we're taking into consideration is people with blocked arteries in their heart called coronary artery disease or prior heart attacks, otherwise known as myocardial infarction. Cardiomyopathy, just meaning weak heart, really, or congestive heart failure. Arrhythmias, which are electrical disturbances of the heart. Peripheral artery disease, which is the equivalent of the coronary artery disease, but of the lower extremity, particularly vasculature. Stroke, and then other traditional cardiac risk factor, or cardiovascular, risk factors of past or present smoking, high blood pressure, which is hypertension, dyslipidemia, diabetes and insulin resistance, and in women in particular, other prior pregnancy-related conditions of heart associated with heart disease, such as preeclampsia, gestational diabetes, etc. And then cancer treatment-related cardiotoxicity specifically, which is the bulk of what we're trying to study and try to be helpful for our patients. As mentioned, the anthracycline and trastuzumab related cardiotoxicities are the most well-known and studied, but with the rapid progress of the development of new drugs, we are also rapidly studying and observing for cardiac toxic effects and how we can best ameliorate those effects or ideally prevent those effects from happening. So going back to this original slide that kind of led us into the last few slides, we'll just briefly go into some of these areas, which is something that we are looking at from a cardio-oncologic perspective on a regular basis. So on the bottom left, we talk about atrial fibrillation. This is a very common arrhythmia, most common arrhythmia in the country, or primary arrhythmia in the country. You might not have it yourself, but you may know a family member or friend that has atrial fibrillation. They're typically on a blood thinner like a Xarelto or an Eliquis or Coumadin, which is an older medicine for this. And we know that ibrutinib is also known as Imbruvica, is a common drug that's being used for a number of different types of malignancies, being used in particular lymphomas, and has really done a great job with respect to CLL, mantle cell lymphoma, and some other conditions in treating them, but does have a higher risk of developing atrial fibrillation. So we are monitoring these patients very closely. Sometimes we're able to use newer cousin drugs to the ibrutinib that may have less risk associated with the AFib. They also associated with the Imbruvica as low platelets. And so we have to manage the stroke risk of the atrial fibrillation with the low platelets and bleeding risk. So this is something very commonly we see in cardio-oncology with respect to this particular cancer agent. That's a more novel agent over the past several years. DVT is a deep vein thrombosis or blood clot, usually in the leg, but can be really anywhere in the deep veins of the body. Thrombosis just being a blood clot. These are associated in particular with some of these immunomodulatory drugs like thalidomide or lenalidomide. Lenalidomide is commonly known as Revlimid, which is very common in the multiple myeloma category, as well as Pomalyst or pomalidomide. And we know that these are having higher risk of these blood clots, both in the veins, but also in the lower extremity arterial vasculature, or the artery side of the body. And so these are things that we are seeing and try to help prevent these types of effects. Heart failure is probably the most prototypical of cardio-oncology, as I mentioned, back into the late 60s when anthracycline cardiotoxicity was first observed. And these are only have grown since additional treatments have been, or advent of other treatments for various types of malignancies have come out. So anthracyclines are on the top of that list of heart failure. HER2 agents just mean Herceptin usually based agents, or things that use a Herceptin backbone. So some patients may be familiar in this group on Kadcyla or Enhertu, or some of these newer agents that combine a traditional chemotherapy drug to the Herceptin to try to target the breast cancer cells. There are small molecular inhibitors, like I mentioned, the VEGF inhibitors that are looking and trying to tackle the vascular growth factors, or to try to change how the way the cancers can bring new blood cells, because the cancers need blood and new blood vessels to support growth. So these agents can help with preventing that from happening from a cancer perspective. However, can sometimes cause some issues with respect to blood pressure as well as heart failure. Proteasome inhibitors, those are things like Velcade and some of its other types of drugs, also used, like the ones for thalidomide and lenalidomide Revlimid, are used a lot in myeloma and in some of the other conditions associated with myeloma. Immune checkpoint inhibitors, these are things like the Keytruda or pembrolizumab that are being very commonly used in certain types of lung cancer, melanoma, and now even being more commonly used in some forms of recurrent breast cancer, kidney cancer, and liver cancer, et cetera. As far as the heart failure goes, these agents all can sometimes behave a bit differently. And so it's not a one-size-fits-all approach with respect to this. And I know sometimes people are wanting a certain protocol or policy of how often we get echocardiograms or how do we treat these, but they're really very different drugs, and they cause heart failure or heart weakness in very different ways. And so part of cardio-oncology is that we are learning how these drugs affect the heart, and really how to best help patients, both with respect to how often do we get imaging or different lab tests, and most importantly, how do we both treat heart failure that's already present, or most importantly, prevent it from happening in the first place. Hypertension, or high blood pressure. As mentioned, this is very common with some of these VEGF or vascular inhibitor drugs, sunitinib or Sutent, sorafenib, Nexavar, bevacizumab, and lenvatinib or Lenvima are all very commonly commonly used drugs contemporarily and currently for a vast variety of malignancies, very commonly kidney cancer, thyroid cancer, liver cancer, as well as colorectal cancers, for certain, shall I say, colorectal cancers. Peripheral artery events, again, this is looking at the usually lower extremity blood vessels for blood clots and other types of blockages, really, of the lower extremities that may come about as pain in the legs when walking, or ulcers that form. Some of the things that cause this that we are particularly looking at are some of the agents that are used for, we call CML, or chronic myeloid leukemia. The prototypical drug for that is Gleevec or imatinib, which does not tend to cause very much of this peripheral artery disease issue. But some of the second or third line generations, like nilotinib and ponatinib, definitely do have a significant increased risk of peripheral artery issues that we are definitely watching closely for. Coronary artery disease is probably the most typical thing that we're looking at as just cardiologists in general, looking for blood vessel blockages of the heart and how to prevent those or treat those if they're there. Certain conditions, or excuse me, certain medications for cancer in particular, some of the medications that are used for hormone-sensitive breast cancers that are, we call ER, PR, or estrogen receptor, progesterone receptor positive breast cancers. These are things like tamoxifen, for example, can lower the amount of estrogen, and over time there's been some literature that shows that reduction has increased the coronary artery vascular disease risk over time, that we are, managing the risk factors to prevent problems. Other category would actually be, this is the first time we're talking about, is chest irradiation, or XRT, some people will call it, is radiation of the chest area for various tumors or malignancies, sometimes for lymphoma, for breast cancer, for esophageal cancer. And so the radiation to the chest can sometimes have off-target collateral damage to the heart or the valves or blood vessels there that we need to be aware of, and can very commonly, as opposed to the radiation that, if you've had radiation previously, causes a lot of burning or breakdown of mucus tissue in the mouth or the tongue or the throat, making it difficult to swallow, etc. The heart-related toxicity from irradiation is usually longer down the line, usually 5 to 10 years down the road or later. And so these are the things that we're thinking about, either while we're currently getting radiation, or when I'm seeing patients 10 years after radiation and there's some issues with coronary disease or the valves of the heart, and we're having to use that information of the chest irradiation for their cancer treatment from 10 years ago. This is a very important aspect to keep in mind. I mentioned the valvular disease and then the cardiac amyloidosis. I won't go into too much more detail, but again, that's associated with multiple myeloma, and we work with the cancer specialists about how best to treat that along with the other conditions mentioned. So to kind of dive in, cardio-oncology is vastly changing. This is not again, a one-size-fits-all this type of approach. This is just one example of a way that we can help create a risk assessment, shall we say. There are many different ones out there. This is a very commonly used one that is gaining some traction, that a lot of people are beginning to use. And part of that, again, is the medication-related risk. With anthracyclines and Herceptin and some of these other agents, as mentioned in the higher risk categories, there's what we call intermediate or moderate risk, then low risk, and then very rare risk conditions. Then we talk about the patient-related risk factors. So is there already a condition that has weakened the heart that has nothing to do with the cancer therapy or the cancer itself? Is there coronary disease or other traditional risk factors, high blood pressure, diabetes? Was there prior anthracycline for a breast cancer or for a lymphoma? How old is the person? And for some reason, we're again trying to understand this a little bit better, but female gender tends to have a little bit higher risk for some of the associated cardiotoxicities that we are trying to study and learn about more. As we can see, this just helps. Again, it's not something that dictates management for every patient just by putting in these boxes and generating a score. It's really a multifaceted approach, but there is some help by using this type of a system to get some sense of what type of monitoring should we be doing and or management for some of these related conditions. So some of the monitoring that we can do is echocardiograms or ultrasounds of the heart, where we take the little probe and the cold jelly and take ultrasound heart pictures to look at the valves, to look at the heart's function, if there's fluid that's developed around the heart, and as well as how often are we doing this. Other things that we're seeing on these monitoring recommendations include EKGs or ECGs, same thing, whether you're using the German pronunciation or the English. And that's basically looking at the electrical system of the heart and how often are we rechecking those. Some drugs can lengthen some of the intervals that are important on those EKGs. And so sometimes we have to be monitoring the EKGs with some degree of frequency to make sure we don't develop any troublesome arrhythmias that can be dangerous. And then laboratory tests. So this CTN is cardiac troponin. So troponin is think of it as a protein that should be in the heart and stay in the heart. So when you draw it in the blood, there shouldn't be anything there. But if it leaks out of the heart, then you can draw it from the blood, and that's something related to heart damage. Doesn't necessarily say what it's from, but it does indicate that there is some heart damage, and then it's our job to figure out what's going on and if it's associated with the cancer therapy. And then management recommendations, we won't go into the different drugs or medications that can be used, but I would say overall, the question is whether we're trying to restore heart function because there's already damage or problems there, or sometimes we're doing things proactively called cardioprotective therapy to try to prevent problems. And there's a lot of ongoing research in the cardio-oncology field and publications on this about what agents are more helpful versus not, and combinations of drugs as well to prevent overall heart dysfunction during cancer treatment. There we go. So we'll continue with the most recent, I would say, unfortunately, COVID, it has happened and it continues to be ongoing. But prior to COVID, or the onset of COVID in 2019, there was a large global cardio-oncology summit back in October of 2019. It was in Brazil. And this is where internationally cardio-oncologists gathered and really tried to define how are we going to advance the field of cardio-oncology. And so some of the things I've already touched upon in prior slides as part of the presentation, but some of these tenets are very important. So what is the role of cardioprotection? As we talked about, what medications work, combinations, what doesn't work, who needs it and who doesn't. Personalizing cardiovascular interventions, so different procedures of the heart, who needs it, who doesn't, how is it going to help us get through cancer treatment. Enhancing survivorship care, which is obviously why we're here today, which is an extremely important tenet of this, because ultimately the goal of any oncologist and patient that is suffering from cancer is to get through their cancer and to come out on the other side into cancer survivorship and to live well through cancer survivorship through the rest of their lives. Building the community of cardio-oncology and oncology together, as far as helping optimize stem cell transplants, preventing blood clot issues, as advancing immunotherapies and other cancer drugs are happening, how do we help with that? And some of these other tenets, which are all very important in the advancement of the field. This is kind of the last part I'll talk about as far as where we're going. So this is just a, we'll kind of late breaking type thing. We'll let you guys in on what we're working on. This is not just a local thing. This is a truly global cardio-oncology registry that the American College of Cardiology, through one of our colleagues in the Florida chapter, Dr. Diego Sadler, and several others through the Cleveland Clinic, Florida, has got together a number of us and organized us. And now this has grown into a very large community of about 30 plus states and state chapters, as well as about 100 actual institutions, hospitals, and cardio-oncology and cancer groups in the country, as well as it's now up to about 20 or so countries involved in this registry. And what is the registry? Basically, it's a research tool to basically be able to enroll patients with various forms of cancers and input the data, including their population data, demographics, what other cardiovascular risk factor conditions they may have, or actual cardiovascular diseases they already have, what cancers they have or had, what cancer therapies they've been on, so that we can over time prospectively be able to ascertain some real good information as to what is really helping people. Because to date, there has been only small studies for many of these things that we are talking about for either cardioprotection or restorative care. And we really are lacking the data because it just hasn't been done before. So this is a really exciting endeavor that we are working towards. And as you can see, the timeline that we kind of put on the slide is where we're going to, and trying to launch this sometime in the early to mid portion of next year, with the goal is over the next several years acquiring a lot of information to actually make changes, meaningful changes for people with cancer and need cancer treatment. So now let's go into the importance to cancer survivorship. So this is a slide talking about childhood cancer survivorship in particular. There unfortunately, kiddos can get cancers as well. Newborns, babies, infants, toddlers, into the adolescent years. and really trying to understand what cancers that they tend to have, the treatments for these cancers, and how over a very long potentially period of time, after these types of therapies, what types of cardiac conditions can develop because of these cancer treatments. The childhood cancer overall survival rate has become very, very good with many of the different cancers that are involved in childhood usually. But we know, unfortunately, that the incidence, meaning the amount of events over a period of time, is actually quite high within about 30 to 40 years of treatment. Almost 1 in 10 of these kiddos will develop heart failure within about 30 to 40 years after their treatment. So we need to be working on is how do we minimize exposures? How do we help limit the cardiotoxicity? How else can we prevent these things from happening? So there are, for example, in the anthracycline world, because a lot of these are used for different leukemias, lymphomas that are common in childhood, is using some agents that help to prevent the free radical toxicity development of these, also as easy as potentially slowing down an infusion or using a infusion instead of a bolus of a drug. This is probably one of the most interesting things that we can do that really doesn't change the therapy or add anything new to it, but rather instead of using a bolus, meaning giving the drug all at once, we extend it over a slow infusion, and that has been shown to really reduce the risk of cardiotoxicity and heart failure associated with some of these agents. So this is, again, something that just was studied over time. Liposomal use of drugs, so encapsulating the drug in a fat bilayer to try to prevent cardiotoxicity. So these things are just some of the issues, and then how do we manage and monitor these things? So we're monitoring echocardiograms, every 3 to 5 years usually, checking the EKGs, and then trying to manage any risk factors, because obviously the kiddos are going to grow up. And, when we get into then the 30s, 40s, 50s, 60s, we can develop acquired problems, whether it's high blood pressure, cholesterol, and have other genetics associated with family history. So family history of heart attacks or strokes may play a role. And so we really want to be extra aggressive at controlling those risk factors or minimizing those risk factors, because we know these kiddos that have grown up will have a higher risk of suffering from some of these cardiotoxic issues. Pregnancy-related survivorship. So this is another very important, group. There's, women that have had cancer, earlier in life in their childbearing years and want to have a family, and they should have a family. And there's definitely some of the cancers, cancer drugs and therapies associated with some of these malignancies can have a risk associated with pregnancy. As when a woman becomes pregnant, there's a lot of changes, obviously, that happen. But one of the big changes is about a 40 or 50% increase in their volume of fluid in their body through the bloodstream, and that takes a lot that the heart needs to be able to compensate for that. And so somebody that has a weaker heart, it may be very challenging and or dangerous at times where it precipitates an actual heart failure episode because of these changes during pregnancy. So some of the research that has been going on, and this is a figure from a 2020 article in the American College of Cardiology's Journal for Cardio-oncology about, helping to stratify or determine the risk for a woman that wants to consider getting pregnant and advancing their family, and how we can help a little bit better in the cardio-oncology world with respect to helping guide and assess that risk, and helping to determine what we can do to help prevent problems throughout that pregnancy. And some of the things that can also be helpful is how we help plan with the obstetricians, not even at the beginning, but also through the pregnancy and ultimately at the time of delivery. And what type of delivery are we talking about? Should we be talking to the anesthesiologist that will be involved? Do we need what we call an MFM, or maternal fetal medicine, which is kind of an advanced specialty obstetrician as a part of the either throughout the pregnancy for monitoring and or at the time of delivery, the way we monitor for arrhythmias, as well as the postpartum or post-delivery care are also very important based upon the prior cancer treatments and the risk for heart problems. So this is a very interesting and very, very important, shall I say, part of cardio-oncology that we're working very closely with our colleagues to help ensure that, you know, women cancer survivors can have the families that they desire. So, you know, obviously cardio-oncology is a small piece of survivorship as a whole. There we are, the little red box down there. You know, as far as the cancer survivor, there's a lot of, you know, the cancer survivor, the patient is obviously, they're the star of the show. And, you know, we're just there to kind of help make sure that that each person, as well as their families, you know, make it into cancer survivorship and are having the best quality of life in their cancer survivorship. You know, managing wellness is obviously a very important part, and this is not to be, you know, made under important. This is really, really important. A lot of cardio-oncology, in addition to these, you know, studies looking at the monitoring or the cardio protection and all these things, there's actually a lot of cardio-oncology trials looking at simple things like we call prehab or prehabilitation. So before you need rehab, trying to get people into good cardiovascular condition even before they need surgery or before they have their chemotherapy. And we know that the risk of heart problems going into either surgery or chemo or radiation is drastically reduced in many cases or many times by the amount of prehabilitation and conditioning of the heart and lungs prior to these different interventions. We know that mindfulness, mindful meditation, guided meditation, all of these types of things to basically maintain and reduce levels of anxiety are very important in controlling blood pressure and also ultimately helping for quality of life during and after cancer treatment. Managing any depression. Depression is very important. As we know, there's a huge link between depression and cardiovascular disease. Nutrition, hugely important. You know, I can't overstate how important nutritionists and dietitians are as far as helping maintain a healthy diet that will help to prevent cancer-related cardiac issues in the future. Sleep is very important. We talked about stress. Physical activity is a part of prehabilitation, but just ultimately continuing a high level of good activity as best as you can throughout your life to maintain health. There is a specific goals of exercise for cancer survivorship that I put at the bottom right here, and this is kind of just reiterating some of the tenets that I mentioned earlier, but it's really, you know, a lot of societies out there are working towards getting the exercise component of cancer survivorship really, you know, shall we say, made more important moving forward, because we know how really important this is, both for really wellness throughout cancer survivorship, and specifically, since I'm biased towards the, you know, cardiac disease world. So let me see here. That concludes what I had for my talk or formal presentation. That's Leo at about 6 weeks in his kind of dubious look there for his question. And this is more what he looks like about a week and a half ago, leaning in to see if anybody has any questions. And then these are some references that I had, and we can see if there's any questions.
Yes, thank you so much for all of that information, Dr. Bauer. And your little guy is certainly a cutie. I do see a question that's asking, if you know a chemo drug can be toxic, why is cardio-oncology not brought in during treatment rather than waiting till you hear heart symptoms appear? breathing, fluid retention, lethargy, etc.?
I think that's a really, really great question. So I think a part of advocacy, this, I will be honest, is that cardio-oncology, as many people don't know about it, including oncologists. I've only been down here since August or September of 2019, to basically start a cardio-oncology program. And most cardio-oncology has traditionally over the past few years, because that's how brand new it is, has been at big major academic institutions, the UCLA's, the cancer centers, of the country, Memorial Sloan Kettering in New York, the cancer centers of Houston, Texas in particular. And that's where a lot of, these places have done an amazing job, because a lot of the initial research and ongoing research is coming from there, and training for cardio-oncology is starting there. But really, as we know, the majority of cancer care is not happening at these major institutions. A lot of amazing things are between research and development, et cetera. But let's face it, the majority of patients don't live or go see a major institution all the time. A lot of this cancer care is happening at the community and local levels. And so it's really, I felt important, because I was at UCLA for 10 years before coming down here, is I felt it extremely important to make sure that we didn't just keep all the cardio-oncologists at these major institutions, and really got out there into the communities. And so I know I didn't travel far distance, but I felt like the South Bay was really a ripe area for a cardio-oncology program, given the great job that oncology as a whole has been doing, and the amazing patients and the amount of patients that are down here. And so, long-winded answer to your question is we really need to. We're trying to get the word out. So we're trying to get and we've been doing that over the past couple of years. Albeit, we'll say COVID did put a little bit of a dent in that, because it's been harder to meet people and do presentations and things. But we're trying to do webinars and do as much as we can to make sure we're really getting that word out there with oncology colleagues in particular. And we've been really working with cancer care here locally at Torrance Memorial, in addition to City of Hope in the South Bay, as well as other smaller private oncologists or oncology groups. And we are now starting to get a lot more of the, shall we say, preventive cardio-oncology referrals and consultations, as opposed to the sending patients only when there's a problem. And so I think I am 100% wholeheartedly agree with you, is that if there are cardiotoxic drugs, whether it's chemo or newer novel agents that are not maybe traditional chemos, but immunotherapies, et cetera, is to have an extremely low threshold to send to cardio-oncology for an evaluation. And we can ultimately, it may just be a single visit, because there's not a concern, versus that there is a much bigger concern that may not have been as obvious to the oncologist. And we are very actively involved in the cancer treatment moving forward, seeing every several weeks or a few months, doing echoes and using treatment. So I've had a very good warm welcome by the oncology groups here, and I'm thankful to them for that, as well as the institution for allowing us to grow the program here, and ultimately to you all as patients, for trusting me and us in doing this. And I'm hoping that we will be able to have a lot more referrals for patients going into therapy, as opposed to just being sent, when a problem happens, basically.
I definitely see someone appreciating you and extending that gratitude, saying, glad you came down here, and that my oncologist sent me to you in time. So,
Highland, hi. I'm glad you're on there. I'm learning Zoom still. Here we go. Yeah, I see you. There you are. Nice to see you.
And then we do have another question here. Somebody is asking, how important is it to continue testing like echocardiogram 5+ years after completion of treatment with a drug like Herceptin?
That's a great question. Herceptin, as we talked about a little bit peppered throughout the presentation, is the brand name for trastuzumab, which is a drug, really, a monoclonal antibody drug that is looking to bind to to cancers that are expressing this HER2. And so what we're concerned about with trastuzumab is typically what we see with trastuzumab is a more reversible cardiomyopathy, or a toxicity that tends to be, it can be very severe, but it tends to be reversible, and we can usually help manage that pretty well. The nice part about trastuzumab for most people, not necessarily everyone, but for most, is that the risk of cardiotoxicity with the use of drugs like Herceptin, trastuzumab, or drugs that use trastuzumab as a backbone. I mentioned a couple of them like Kadcyla, Enhertu, et cetera, where they use Herceptin base as a backbone and put something else on it to kind of target the cancer. Those tend to be limited to the time of which we're using them, or for a short period of time thereafter. They don't tend to have as much of the super long-term cardiotoxicity risk compared to some other ones, like, for example, anthracyclines. So those are the doxorubicins, the idarubicins, the daunorubicins, or even mitoxantrone, which is sometimes used in multiple sclerosis. Those tend to have some additional risk outside of the first year or two. They can have chronic cardiotoxicity risks for years thereafter. And so we do have to talk about screening echoes for longer periods of time. But to answer your question, as far as Herceptin, usually we don't have to be using, we don't have to be getting echoes in the 5+ year mark, usually more into the 1. During the treatment is every 3 months. That's pretty typical, and the data does support that. Once the treatment's over, it's usually a good idea to get it at either the 6 or 12 month to ensure there's no kind of later portion of cardiotoxicity. But usually for Herceptin, if that's the only drug that's involved, for 5+ years, we're usually in good shape.
Great, okay. We've got another question here asking if you can talk a little bit more about Prehab for cardiology.
Oh, yeah, absolutely. So Prehab is, I forget who coined that term, but I love that term because it kind of is the idea of, instead of always doing rehabilitation or doing something after the fact, very much as you had mentioned earlier about, why don't we do things before bad things happen? And so prehabilitation is the idea of helping the cardiopulmonary and cardiovascular system be as highly conditioned as possible before going into cancer treatment. Does it necessarily make the cancer go away? I'm not saying that there's studies that show that it helps to eliminate the cancer per se, but it definitely has, I would say, multifaceted benefits. Number one is it helps to reduce cardiac risk even without cancer treatment or cancer therapy. We're trying to get people into exercise conditioning just for overall health and lowering cardiovascular risk over time. But going into cancer therapy as well as surgery in particular, we know that doing prehabilitation has really helped people make it through either major cancer operations and or get through chemo, especially rough or toxic chemotherapeutic regimens with a lot more success and a lot less symptoms. Both, just kind of the symptoms of getting through chemo, as well as how you feel. Fatigue, the tiredness tends to be less bad with people that have really prehabbed prior to starting the toxic chemo drugs. Sometimes there's less nausea involved. A lot of times there still is because they're very toxic to the GI system, but we can still usually help to reduce some of that a little bit. And then there's the other medicines to help with that. Going into major surgery, this is definitely something we've seen not just in the prehabilitation for cancer surgery, but all surgeries really, is if it's safe to undergo prehabilitation, then it really helps to get through any type of major surgery because you're conditioning the cardiopulmonary system so that you can make it through the anesthesia and the stress of the surgery to the body. And then really the use of continued exercise and overall health and wellness going into cancer survivorship, I think, is of paramount importance, and not just doing this prior to a surgery or prior to chemo, but really making it a lifelong goal to kind of incorporate that into the cancer survivorship portion, because really it helps with many things, whether it's stress reduction, anxiety and depression reduction, overall building the body up so you can do more activities and enjoy the quality of life. So, being able to travel, hopefully again soon, but continue to at least enjoy, local travel or travel as it comes back, enjoy times with families, doing, activities, being able to go to that Disneyland trip and walk around and feel like you're enjoying it and not being tired and fatigued. So I think all of this is very, very, very important. And, it's not a drug. It doesn't have a side effect per se, other than, tiredness or fatigue. And obviously, I'm saying it almost as a blanketed statement that this is good, and it really is for the most part. But if there is any particular chance that you have a cardiac issue or something that's undiagnosed, it's definitely something you may want to check in with at least your oncologist, or have a referral to someone like myself as a cardio-oncologist to be sure that it's safe to do this type of either prehab or ongoing exercise conditioning. But it's usually something that we can, check people out and make sure that they're in good shape and safe to do so.
Okay, great. So I've got one more question here. It's asking, is there cardio risk with more targeted cancer treatments, such as targeted radiation for prostate cancer, and even testosterone treatments, which augmentate?
Sure. Very interesting. Actually, as far as we'll start with the radiation, targeted radiation component. So there are a lot of especially for prostate cancer, a lot of targeted radiation type therapies, whether we're talking about traditional radiation therapy, proton beam therapies, whether they're putting those little implants of radiation into the prostate themselves. So the more localized you can be, the better with respect to at least cardiac, risk per se. The more the less targeted you are, it's definitely something that has higher collateral damage to not just the heart, but really any other structure. So that's why it's always usually a goal of radiation oncologists and radiation physicists to really try to target as best as possible and limit the collateral damage using shielding or specific types of treatment. Like I mentioned, proton beam therapy, which is a very specific type of therapy. As far as the testosterone treatments, it's an interesting question you bring up. I was very excited for a second there. There was a study called the PRONOUNCE trial that was being reported at the European Society of Cardiology, or ESC Congress, just this past weekend. And unfortunately, it was stopped early as far as they didn't continue the trial, but at least for the portion of the trial that they had, it didn't seem to be that there was a very high risk of using the agents that basically are against testosterone. So for prostate cancers that are feeding off the testosterone, and people that are using agents to suppress testosterone or basically treat hormonally, this is something that has been a controversial question for some time about, is there significant increased cardiovascular or cardiotoxic risk? And really, it's I would say it's a little bit of a still question mark. However, the fact that while they did stop the trial early, the fact that they didn't show any major statistically significant signals for harm is good, is beneficial. It's probably that there may be a slight chance that there's a risk, but they just didn't keep the study going to see over a longer period of time if there was any problems. But again, there seems to be not too bad of a risk there.
Okay, great. Well, it looks like that is, oh, wait, one more question. How long before surgery should prehab start? Which I think was a follow-up question to what you were talking about earlier.
Sure. Good question. Honestly, I wouldn't say that there is any real data to support an exact amount of time to start prehab, prior to a surgery or prior to chemotherapy. There's more data in the rehab literature, especially for, after surgery. We have a lot of data for example, after heart surgery, we do things called cardiac rehab. And there's a lot of data about how long, how many times a week, for how long, shall I say, to get people to a certain level to get the benefits we see with cardiac rehab. With prehab, I would say it's an ongoing question about, we don't have that literature yet about exactly, how many times a week for how long. Right now, it's, I would say, a little bit more of a casual discussion because it's not a formalized program, that we send to a rehab or a prehab center and do this. I would love that. Maybe that's where we'll be able to go. But we don't have the data to say is, for how long before, how many times a week before. So I think for now, I try to get people at least to, target, a few times a week, maybe, 30 minutes. The AHA recommendations for exercise in general is 5 times a week of 30 minutes a day of moderate intensity, which, that's based upon, a generally healthy person. And, there's, reasons that if you're getting chemo or getting different types of agents in our cardio-oncology patients, that it may not be as feasible to target as high a level of exercise, but that is, what we try to target it as best as we can, because we know with a good amount of data that level of exercise is definitely beneficial for cardiac health and to get people into and through surgeries. As far as how long to do it, I would say I try to get, cancer surgery is tough, right? Because, as opposed to maybe like a truly elective knee operation that you have to have, or a shoulder surgery where, we can really wait without bad things happening. Cancer surgeries, sometimes we don't have the luxury of time, and it needs to happen. So really any time that the surgeon tells us, say, okay, I can give you guys, 4 to 6 weeks before we're risking, a problem with cancer spread, then we'll take it. We'll take that 4 to 6 weeks and we'll work on creating an exercise program that's reasonable for that particular person, and make sure they're in good a shape as possible getting to the surgery.
Well, thank you so much for all this information. And I know that the handout that's going to be included, that you approved, also includes some tips and ideas about staying healthy. And there's some links there as well to protecting your heart and so forth. So I think what we will do, because we are close here to the time, we will go ahead and finish up with the evaluation. And so I'd just like to thank you for your time and for your knowledge and sharing this with all of us. So thank you, Dr. Bauer. And of course,
thank you guys all for having me, and thank you for having the interest and learning about cardio-oncology and all the things we're working on. And honestly, the most, thank you to all patients and cancer survivors for everything you guys do and kind of supporting us through our journey with trying to help out.
Yeah, well, again, thank you so much. And for everybody else, please stay on. The questions are going to come up onto the screen.